have to be watching a lot. So for those of, I guess it is on. Oh, thanks for staying around for the last part of the morning session. I'm Roxy Albrecht. I'm the president-elect of the association. And as president-elect, I was told about a month ago that I was in charge of this case presentation session. So I was like, oh, okay, I haven't been collecting cases. So thanks, Dr. Margulies and Dr. Todd for letting me know ahead of time that I was supposed to be doing this. But so I thought, well, let me just get a few cases from my week on trauma and my week on EGS that I had in the last month. So Rob Todd had said, hey, keep them simple. So I'm going to keep them simple. And there are things that we just see probably, and you all see if you do acute care surgery like I do on an everyday basis. So I want to kind of introduce our panelists here. So Amy Kwok, to my immediate left, is a associate clinical professor in the Department of Surgery at the University of San Francisco Fresno campus. She stayed on in Fresno after doing her fellowship in acute care surgery at that institution. She's also the program director for general surgery for the residency program, and she's a vice chair for the Northern California American College of City Surgeons Committee on Trauma. Next is past president Dan Margulies, who has been heavily involved in the Committee of Trauma on a national level and has been previous chair of the Verification Review Committee. He's a professor at the University of California, Los Angeles, and chief of the section of trauma emergency surgery and surgical intensive care at Cedars-Sinai in Los Angeles. And he's a professor of surgery at Cedars-Sinai. Sorry. Next is Rob Todd. Rob is again a past president of the Southwest Surgical. He served most recently, most of his career in the Houston area and took a small respite to New York for a period of time, and now is at Grady Hospital as the senior vice president and chief of acute care surgery at Grady in Atlanta. And then on the far left is Justin Regner, who is a associate professor of surgery and trauma medical director, division chief of trauma and acute care surgery at Baylor Scott and White in Temple, Texas. And he also is a vice chair for the Committee of Trauma for South Texas. So I put this slide up because we have a schizophrenic title at our names at the University of Oklahoma. We've had 3 names in the past couple of years, so I don't know which one to use on my slides anymore. So first case is a 35-year-old female who's auto pedestrian, 40 miles per hour. Pre-hospital, she's tachycardic. She's got a narrow pulse pressure, 154/100, and her shock index is 0.9. Respiratory rate is 40, O2 of 97. She's on a non-breather. Her GCS is 8. EMS tells us pre-hospital she has a unstable pelvis, open femur fracture, and some bruising to her lower abdomen. So first question is, I'll start with you, Amy. Do you have any pre-hospital massive transfusion triggers? And would this patient meet that criteria?
We do not have pre-hospital MTP triggers, but looking at the scenario, things that are worrisome is the tachycardia, the unstable pelvis, and the open left femur. So we would have a very high suspicion for initiating MTP once the patient is in the trauma bay.
Okay. Anybody else on the panel have use any of the ABCs or pre-hospital massive transfusion triggers?
Typically,
other than
ABC,
you having to get down there and say, hey, call for blood before they get there.
yeah, typically it is good to have some standardized ones like ABC or shock index, and then you'd have the blood available because, without having to think about it. But we compared ours to those data, and our surgeons always ask for it when it's needed. So we didn't really see an advantage to that, but a lot of places do use that. The main thing is to get the blood when you need it. And this is certainly a patient that you'd like to have we would have activated the massive transfusion protocol prior to arrival of this patient, given that she's coming in with a heart rate of 140.
No? Any other comments?
I think for our institution, we have whole blood and the ED waiting. One of the things that we run into is we activate an MTP while the patient's in the trauma bay, and then the patient goes to the OR, the blood bank gets confused about where to send the blood. So we don't try to activate the MTP till we kind of have a destination. We just use our ED fridge and the whole blood there.
That is a problem, sorry. That is a problem, and it's really something everybody should pay attention to. You know, they don't want the blood bank running around trying to find where the patient is. So whatever is your system, it is really useful to have them clearly know where to bring the blood. And then I agree, we similarly have a refrigerator in the ED just so that we can start grabbing blood whenever we need it, regardless of the MTP being there or not. And we use whole blood as well, but we also have a refrigerated massive transfusion protocol process. So it's not just a cooler, but the blood is in a refrigerated container, which really makes it useful to wheel around the different places that the patients are going without wasting the blood. It keeps it at the set temperature. And then that's really useful because we can activate, you know, even if we're not sure we're going to use the blood, because it's not going to be wasted. It's kept at the temperature. And when we don't use the blood, it just gets rolled right back to the blood bank, and it's not wasted.
So no coolers,
It's not
a little
coolers.
refrigerator.
We moved to this little portable refrigerator, and we're so happy with it. And then the question came up, well, why are we just using, 6 units of blood in it? Why don't we put more? So we doubled it. Now our cooler has 12 units of packed cells and 12 units of thawed plasma. And it's okay because we don't waste it. So we actually have a lot of blood right away available.
I was gonna say that's one of the benefits of being at Cedars-Sinai is you can have a nice little refrigerator carry around.
And then those are stuff that
Yes, it is.
county hospitals, we still have coolers. So yeah, this kind of leads to blood wasting of jars. I've seen photos and we've talked about that. And then we look at the price and we're like, oh my gosh, are we going to be able to afford this? No wonder he stayed there for his entire career and Rob's run around all over the place. Okay, so you kind of answered some of my questions. Do any of your places have the helicopters or EMS that are doing pre-hospital blood transfusions, and what do they carry?
In Atlanta, some of them carry blood. We were about to start a whole blood in the Grid EMS itself currently. So.
Thankfully, we're near the South Texas RAC, so all of our area EMS agencies have whole blood. We thank you for that, Dr. Stewart. None of our ground agencies have any blood.
And Amy, what about in Fresno?
We have whole blood in the trauma bay, so 2 units there with a fridge available. I'm not sure about our pre-hospital transfusions. I do not believe we have any for our ground.
Dan, what about?
So I think it's a good idea if you have long transport or you get patients, that are taking a while to get to your place, but we don't have long transports. We're in such a heavily populated area around us that our transports are very short, and we do not use blood in the pre-hospital phase.
No, thank you. And then, so if you have component therapy, most of you have been talking about whole blood, but component therapy, if you're using that, what do you all give first if you don't have your whole blood available? You give plasma first, you give packed cells first. Go ahead, Amy.
We give 2 units packed cell first.
First, Dan.
Well, we do also start with packed cells, and we have the plasma thawed, so we start right away with 1:1:1. Talking with Holcomb, he likes to start with platelets right away because he's really convinced that the platelets make a big difference. So we've not quite gone to that, but we've moved that up to earlier. Rather than waiting till you've given a lot of blood before giving platelets, we also like to put the platelets in pretty early in the resuscitation.
Yeah, if we don't have whole blood, we go with RBCs and then plasma, all of which is in the trauma center. Our problem with platelets is we just don't have enough. We rarely have enough for the hospital in general, so we don't have that luxury.
If you use them early, you won't have to use so many of them.
Justin, what do you all have whole blood? So
We
that's
have whole
probably-
blood, and then if we don't have whole blood, we actually have liquid plasma. And I would encourage your hospital to consider liquid plasma over thawed plasma or FFP, as it keeps all the cryo in it.
Yeah, we have never frozen plasma, so we start out plasma first. We have to call for platelets. We have a shortage of platelets, so it's plasma then red cells. Kinda
Can
like
I ask
going
a
that
question
process.
about the whole blood?
Sure.
So we've been using it for a long time now, but we've started so early that we were really conservative, and we were not using it in females in childbearing age initially. And we're moving away from that now. So I'm wondering what you folks do, because we
Yeah.
used it and we just set
My-
it up on the males.
You predicted my next question. So do you have limitations on who gets whole blood?
Yeah, we do not. We use it in everyone. And we use O positive, less than 1 to 200, and then leukoreduce is just so what they do in the southeast. So it's leukoreduce, but we use it in everyone.
So who then, so if you have an O negative woman of childbearing age who got O positive, even low titer, what is your process of notification of those individuals and following them?
Yeah, so it's interesting. So if you look at alloimmunization, I guess on all comers, it's about 80%. And the ones who get massive transfusions, truly with whole blood, is probably less than 3%, even less than that. And it's probably because of the overall shock. And so we don't worry as much about it. Some of the data, people who do a lot of it, they may have one patient. And then you would talk about, immunoglobulin, some sort of red cell transfusion at some point, but we haven't gone down that path yet.
I think it's a little more, or is it still sophisticated down in South Texas where you involve some of the OBGYN and the blood bank itself follows these patients or?
Yeah, we don't discriminate, and then our blood bank follows everyone and gives RhoGAM from anyone who's RH negative. But I agree with Dr. Todd that very few patients, probably less than 3% is what I think the most recent article said regarding who gets potentially alloimmunized.
Okay. And what about, Justin, this goes along with your multi-center trial that you want to put together as far as if you're doing massive transfusion, is there a policy or protocol at your institutions in regard to labs, viscoelastic testing prior to and during the massive transfusion? Do you give calcium?
So, I mean, I think that's something that a lot of people want to study. I think most people would now say that calcium or hypocalcemia is probably part of the tetrad of death. We are in the process of instituting a calcium on arrival or ionized calcium on arrival as part of our ISTAT. And then we do TEG before, obviously, if they are by ERMS, they've already had whole blood. We try to do a TEG prior to giving it any whole blood product. Regarding when to give calcium thereafter, I think all of us, probably if you ask our anesthesiologists or our ICU colleagues or even us, we all want to give it. Do we know when to give it? Probably not. Do we get it after 2 units, 3 units, 4 units? Is it 1 gram? Is it 2 grams? I don't think anyone has any data on that whatsoever. But I do think as part of a MTP process or massive transfusion process, that will become, the next generation.
It's
I think
So-
it is important to give it though. So, whether you're measuring it, I find it like a failure if we measure it and it's low. So I think that we empirically give calcium, as frequently as we can to make sure that we don't have it ever be low, because we don't want to add that as a problem for the bleeding patient. And you don't want to find out in your review afterwards, oh yeah, he bled a lot and we didn't give the appropriate amount of calcium. So we try to just stay up on giving it. It's not really harmful to be giving it during the resuscitation.
Yeah, I think point of care testing in the OR, they do a lot more than we do. If we do go from the ED up to our resuscitation bay up in the ICU, they're just kind of road at it. They're not so good at the other labs that we want to get about repeating TEG after, certain number of whole blood or certain number of component therapy. We don't always get our other testing, but we do get point of care blood gases. So So she arrived and actually we have pre-hospital massive transfusion protocol. And she didn't meet those criteria, but luckily the faculty that was there was like, oh, she's got a narrow pulse pressure. She's tachycardic, even though her shock index was not appropriate for pre-hospital blood. She had had called ahead and said, yeah, we need whole blood down here because we do have a hemobank in our institution, but that's component therapy and we can call for whole blood prior to arrival. So the whole blood's there. She's hypotensive. She's still tachycardic. She's breathing okay, oxygenating okay at rate of 16. Her GCS is 18. So, and this is kind of the picture of what she looks like. There's a huge contusion or ecchymosis, abrasion over the anterior pelvic region. And if you touch in that area, you really can't feel a symphysis pubis. And then she's got the open femur fracture on the left side with bone poking out of that 4-centimeter hole. Some abrasions on her back. And if you can't read what that little thing is pointing to right between the crack of her gluteus is, that would be an intern writing blood from rectum. Okay. So where do we go from here, Dr. Kwok?
So standard ABCDs first. And so I'm concerned about her GCS of 8. I'd like to make sure that we at least address her airway, that she's protecting her airway, that she's breathing. Her SATs are okay right there. And then can immediately start the resuscitation with fluids and blood and recheck her vitals. The other concern is the blood from the rectum, the unstable pelvis, and the femur fracture on that side as well. So I would consider putting a pelvic binder on as well after we check a pelvic X-ray on her.
Okay. So interventions. She got intubated, GCS of less than 8, but she was protecting her airway. She had negative fast and blood transfusions were started. When she was rolled, a binder was placed underneath her. So we roll before we get our chest x-rays and our pelvis x-ray. So they were prepping for this ahead of time. And then we got our chest x-ray and pelvis. So chest x-ray, really not too remarkable. Looks like she took most of the blow. And there's her pelvis x-ray. Okay. Yeah, whoa. And and these are her vitals. We take them every 5 minutes in our trauma bay. So these are her initial vitals, the 95 over 77, and she remained tachycardic. So I think I don't have to belabor this. We put in some lines, put in a 9 French introducer. We'll sometimes use a 12 French MAC catheter, but a 9 French subclavian. We put a femoral A line in. We'll get to that in a little bit. And we gave her 4 units of Paxil, or she didn't fit our whole blood. We don't use it in women of childbearing age yet. So she fit the component therapy for our pre-hospital MTP protocol. So she got 4 plasma and then 4 Paxils during that resuscitation period. And you can see she was kind of a transient responder to maybe a responder. So where do we go from here? Dr. Margulies.
So stepping back, don't forget to give the antibiotics for the open femur fracture and possibly open rectal injury from the pelvic fracture. So, when they're really sick, those are the ones that the antibiotics get lost, and you don't want to review it and find out that you missed giving it. So certainly give that as well. But this patient is definitely, in trouble, sick. I'm glad you put the subclavian line, because if you put in femoral line, there's risk for DVT later. So an A line is useful potentially this is a potential patient for a Reboa. If you do that, if you're comfortable doing it. But we would go to the OR and pack this pelvis, and then potentially have IR available if that didn't stop the bleeding as well, preperitoneal packing. And an X-fix, because looking at that picture, that the sacrum is opened up and the back of the pelvis is quite open. And I think, bringing those things together with an X-fix can really stabilize it. And very often you don't even need IR after doing those 2 things. No,
other-
I'm sorry, but the head injury is a potential problem, but I still would go to the OR and fix this stuff before going to any CT of the head, which is what, people's concern is, and they're going to get anxious that we don't have a head CT, but you got to stop the bleeding first.
Yeah. So any other,
I mean, I'd agree with what Dan said. I mean, I think we probably wouldn't go to the OR. If we thought they were really a responder, we'd go to scanner. I guess the question is how much of a responder is this person with that last blood pressure and heart rate in the 140s? So I don't know if they're really responding, quite frankly. So this is somebody that would get a Roboa most likely at our institution. And then from there, it really depend on whether you go to IR, OR. Some people with P Roboa, we've gotten more aggressive about going to scanner. So you absolutely know what you're going to treat at that point in time. But that's kind of on the cusp, I think, for us.
yeah, I think that's a real judgment call. And in this case, it was the judgment to go to CT because they could keep it up with it, but they did put the femoral line in case they needed to put a Roboa in that situation.
You don't want to deteriorate in the CT scanner.
Yep.
So this is really, that's where the patients can really have a
Yeah.
problem. So one thing is you've got the A-line in, which is really great. And you both use it to upsize for a Roboa, but also send an ABG early because that'll tell you in how much base deficit they're in and really, can tell you whether, how they're doing because this patient could deteriorate. I would not go to CT.
Yeah, so CT on the arterial phase
didn't.
didn't really show any extravasation in the pelvis. And you can kind of see here that there's a huge right extraperitoneal hematoma going up. It actually went up to the kidney level. And then these are on the delay films. You see that there's a little bit of contrast out in that right retroperitoneal area. So similar, whether you go to the OR before this or now you have this information, we had this information, so they headed for the OR. Would anybody go to angio with this now? You don't have a active arterial extravasation, Dr. Regner?
I mean, I think
Justin?
no matter what as narrow as those vessels are, I wouldn't trust that there's not an arterial injury. I would assume this is an arterial bleed till proven otherwise. The only way we'd prove otherwise is with angiography. I think for our institution, when we see an unstable patient with an unstable pelvis, we basically activate both IR and ortho at that very moment in the ED, and they will meet us in the operating room for a combined thought process on this.
Yeah.
The other thing I'd want to know for sure was it truly blood in the rectum or blood in the vaginal fault?
It was on vaginal exam, didn't have any bony fragments in it, and it was blood in the rectum.
Okay. So, I mean, definitively, you're going to do obviously some form of XLAP, but I'd like the pelvis stable prior to that. And I'd like for IR to have already squirted her to rule out arterial bleed while that's going on. She'd also probably get preperitoneal packing during this, but we'd explore the abdomen through a supraumbilical incision.
Dr. Kwok, you had a comment?
Yeah, so pseudo hemodynamically stable, I would probably take this patient to IR. We have a pretty good response time from IR. One of the things that we've run into with these really bad pelvic fractures is that when we do the preperitoneal packing, our incisions go right into their incision for their XFix or their ORF, and they get very unhappy with us. So,
Yeah.
so one of the things we try to do is at least see if IR can stabilize them and then go from there.
Yeah, we learned to stay high because we get scolded the same thing.
Yeah, I mean, I think a lot of it, and that pelvis is closed down pretty well, but if it's closed down pretty well, we'd probably go to IR and then to OR for an XFix and our surgical procedure.
So we're fortunate. I could have showed you that a little bit. So maybe I can back up. Nope, can't back up. So we have a hybrid room. So, and we have what's called an embo now. So we just call embolization. So we call the IR attending. We say we have an embo now. We'll meet you up in the hybrid room. So they come in and we head up there. And similar to what you all said, we put a Roboa in first to stop potentially any ongoing hemorrhage, then did a little mini exploratory laparotomy and got down into that preperitoneal hematoma just below the umbilicus and put some packs down there. And then they came in to do angiography. And angiography kind of shows, to get through this, her right iliac is completely out. And so a little bit more there. No, they actually had access through the right since we had the Roboa in the left, and did what's called a Wagman loop to come around and embolize that right iliac. And then from there, since they did a flexible sigmoidoscopy, saw an extra peritoneal low rectal injury, decided to do a loop colostomy, and then close her upper abdomen, and then left her packed to come back at a later point in time to take out the packs and then deal with the big Morel lesion that you have around the side there. Okay.
To take the packs out. How
Oh, when
long-
did
how
it-
many,
she-
how many days did you leave?
She
it
went
there?
back the next day to have the packs taken out, and then they put a back in there, and we're kind of at that phase right now.
I think
of,
I think that's good. I mean, I think
yeah.
it's really important to not leave those packs in too long because they, after they can get infected.
Yeah, yeah. And then they ex-fixed her at that same time. So all those things got done. So just this is kind of an area of my interest is these two cases. One patient is a morbidly obese male who was a restrained driver in a semi rollover. He came in hemodynamically normal, hypertensive. And the other was a 60-year-old woman who was a rear seat passenger in a motor vehicle crash, came in hypotensive and normal cardiac and received again our massive transfusion protocol. She had peritonitis. So again, our hemodynamically stable patients, we will take the CT scan. And so
But can I go back to that last case? I was advocating not going to CT and the patient went. And I was wondering, was it because you really needed the head CT to make sure what was the rationale for going there? Everybody wants a CT, but this was a patient that,
Yeah.
you didn't really do much on the findings of the CT. You packed the pelvis, you took care of the patient.
yeah, discussion with the team at the time was, I'm not sure they trusted their fast, and they were trying to figure out where to get what to do. Next is, okay, should I put in a Roboa in the ER? Should I then go to CT with the Roboa up and let it down during CT? So I think there was a bit of consternation about which place to go, but I think it gave useful information for them. Yeah, I think I would have probably gone up straight up to the OR, done pre-pelvic packing, and then a laparotomy.
Yeah, I mean, I think in this patient, it didn't benefit them, but if all of a sudden they had a bleed in their head, then they get a cranium in the OR at the same time. Otherwise, you're going to the OR, doing all this stuff, spending all this time. The bleed's worsening. You go back down CT scan. Now they have a horrendous bleed, a devastating head injury. You go back to the OR, and you're kind of doing futile care at that point. So I think you can kill two birds with one stone. It's kind of nice.
It's risky.
So I'm going to show this video, so watch closely. These are the restrained drivers. So if you all saw that, they had a fairly significant flank disruption as well as a periumbilical disruption. We originally thought this guy was so fat that he didn't realize he had an umbilical hernia, but then when they went back to examine him, he had an acute anterior abdominal wall disruption as well as a right lateral wall disruption, and no evidence of mesenteric injury, no hemoperitoneum, no evidence of any bowel injury or abnormal flow to any of the bowel. So totally normal CT scan other than these abdominal wall disruptions.
That
So-
can be picked up on the physical exam before going to CT. So, when you feel
On
there's
that guy, you could not feel his hernia.
I know it can be difficult, but when the bowels are sort of out there on the side of the abdomen, just hanging out there, and you can sometimes feel them.
This guy is what I'm from Iowa, and the people in Minnesota used to call Iowans Iowa units, and this was like a 5 Iowa unit, okay?
Yeah, Dr.
This
Margulies
was
is used to the
huge.
Southern California patients.
Yeah, I don't know where. So do we just admit him to the ICU and monitor?
There's some clues,
do we do with
there's
this
usually
guy?
a little
He's
bruising
got a
around there.
negative
and
CAT
there's some
scan except for
peristalsis of the
abdominal wall
skin.
disruption. What do we do? Dr. Quag?
So given the traumatic flank hernia and abdominal wall hernia, one of the things I am concerned about is bowel injury. So both ileocecal side and the sigmoid side. He doesn't have any active mesenteric bleed at this time, so I would admit him serial abdominal exams and serial labs NPO and kind of see where he goes.
Okay. Dr. Todd? We already know what Dr. Margulies would do. He would have just operated on him because he could have felt this on physical exam.
And avoided the CT. Yeah, when you feel the viscera out of where it shouldn't be, that's an indication to fix it, go to the OR, put it back, examine the bowel, and you can save the radiation.
I don't know, you
Yeah.
must be a better, yeah, I've done this for a number of years and see probably 2 or 3 of these a month lately. And you just have no physical exam on these guys
Yeah,
that I know of, but
usually if it's an isolated flank, we would not fix that acutely. We would do that in an elective fashion afterwards. With the intra-abdominal one, that might change our thought processes.
okay.
So
Dr. Regner?
So I think at some point we'll have to grade these flank hernias. Sometimes you see just disruption of the muscle from the iliac crest or the paraspinal muscles, but the peritoneum appears intact. In other words, there's no herniation of the intra-abdominal contents. I think those patients are probably fine to treat on an outpatient or, expectant course. This patient had probably a third of his abdominal contents in the flank hernia. He's a little different than your typical, just small little flank hernia with the peritoneum contained. I would probably opt on repairing him to prevent future obstruction, since my team has sat on these patients before, and it's come back to haunt us. So I would probably be pro operating on patients with bowel in the hernia sac as opposed to just abdominal disruption from the musculature, but the peritoneum appears otherwise intact.
Yeah, I'm really of that feeling as time has gone on now. I used to kind of sit on those, but these morbidly obese patients with a lot of that bowel out there really stretches their mesentery. And I think if they don't have ischemia at the period of time when they start getting up and moving, they stretch it and then become get some relative ischemia and then perforate, and then it's a real mess to fix those. So I've leaned more on the side now of kind of going in there, not in the middle of the night, but more on an elective basis the next 1 or 2 days to fix those in the morbidly obese with significant amount of herniation.
And it's not uncommon to see the mesenteric have been torn, and it can either be bucket handle or just bleeding. And I wouldn't rely on the CT findings to make sure that it's, not that.
Yeah.
And it's better to just look at it.
Yeah, amazingly, he had no serosal tears of his right colon, which you would have thought of. His mesentery was fine. He had just shoved all that bowel out there. And when we took him the next day, we just didn't want to sit on him too long. So then the other one, so she was hemodynamically unstable and had peritonitis. And so she went up to the operating room, had 3 liters of hemoperitoneum. She had active bleed from the small bowel mesentery in 2 areas, both a devascularized area of the jejunum and of the terminal ileum. And there was a 50 centimeter bowel between those 2 areas that was viable. So they did a jejunal resection and a ileocolic resection, and then noticed that there was this large pocket with the right colon and herniated bowel out into it. So that's what they did. So you've taken out the devascularized bowel, you've stopped all the bleeding. Do you put her back together? Do you take out that 50 centimeters and do an ileocolic, or do you do 2 anastomoses, and do you repair the hernia at the same time? Dr. Margulies.
So definitely you took care of the problem with the bowel. I would put it together, definitely do anastomosis. I don't see why you wouldn't. And then it's nice to just have the viscera back in the abdomen. So whether some kind of a hernia repair is indicated, whether it's a temporary one with just Vicryl that's going to break down and you can deal with it later, but it's nice. I'd rather have the bowel in the peritoneum than to hanging out to this hernia that it's just not going to be helpful.
Yeah, I would agree. Definitely put them back together, and then some sort of tissue repair. Probably nothing biologic.
So what if I told you that, she got several boluses of phenylephrine during her case. She had a total of 3,000 of whole blood given to her, and that's her base deficit of -6. Her hemoglobin's 8, pH is 728. Would you do the same thing, put everything back together and fix the hernia? Dr. Wagner?
I mean, I would hold off. On these type of injuries. I would never fault anyone for not reanastomosing at the time of surgery. I don't really trust blunt abdominal wall injuries or mesenteric injuries in the OR on the first take back. I think there's still at risk of thrombotic events later on. And I'm not sure we know within the first hour who's going to have issues 12 to 24 hours later. So I would not fault anyone for saying, you know what, we're going to close this big injury and we're going to take a second look just to make sure everything is as we expected it, all the bowels still alive.
Okay, so that's kind of,
I'll just comment. So I know a lot, that's done a lot. And, you know, we're going to get out, just pack it, leave the bowel in discontinuity. But I think you can still make a decision to come back and look at it, even if you put the bowel together and leave the abdomen open, and then you can assess it, and you can always resect more if you're not happy with it. But if you don't put it together, you're essentially leaving the patient with a closed loop, and the bowel doesn't get very happy from all the, it's not absorbing fluid, and the fluid's coming down on the small bowel. If you don't put it together, you have essentially like a closed loop, and the bowel actually gets worse. So unless you're going back really quickly, my preference is put it together and then decide to leave them open and come back and look at it if you want to. You know, it doesn't take very long to put the bowel together, but I think they do better physiologically.
Yeah, I mean, I think I would agree with Dan. I mean, I think given the sequelae of having them in discontinuity, I mean, the LA data would say that actually portends worse outcomes. So I'd probably be inclined to put them back here if you're that worried. Come back in 24 hours, take a look.
yeah, I think if it's not too bad, put it together, come back 24 hours and look at it. You can always re-resect and redo it, those type of things. But yeah, I'm going to run through this. So basically, she had, you know, big lateral abdominal hernia again. They didn't put things back together, but second look went back. When would you take her back if you didn't do an anastomosis?
Once she's resuscitated, so
Once she-
12 to
next-
24 hours.
So what your, yeah, serial-based deficits or gases, okay. So you're back in there, you've put everything back together. I think we've talked about the hernia management. Most of you all would fix these type of things. She again was similar to that last patient. And then, you know, what do you do with that Morel lesion that's there, and what do you do with the skin?
Meaning skin open, closed?
Yeah,
Oh, absolutely open. So I mean, I think just your risk of SSI in these patients is extremely high. Obviously, unfortunately, we know we're all kind of docked on that now nationally if we don't do that. And so we have an aggressive colorectal bundle that we'd follow, irrigation, et cetera, but the skin would be left open. If they're stable, we'd go and put a Provena, or if it's skin closed, Provena. If not, we put it back in there and just change it out.
when I get to, these are just some of the repairs. They're not easy, you know, they're all not very thin, and they're down in a hole, and they're hard to get to. And I think if you do a bowel anastomosis, as Dr. Margulies said, putting the muscle together the best you can. If you have to put some Vicryl mesh or some absorbable mesh in there in these acute settings works. If you can go back and, you know, do a like in the first one, what we actually did was develop some extraperitoneal flaps to close the muscle, and then put a more permanent mesh in there, like a dual type of mesh with a absorbable component in it.
Yeah, and I agree. You don't want a wound infection, but you know, if you didn't actually have a colon injury and these were all small bowel and you took care of it, you know, removed all the contamination, cleaned it out. I mean, and you protected the skin during the operation. Those we typically actually would close the skin if you didn't have a colon perforation. Colon perforation, you know, then absolutely leave it open. But small bowel, the incidence of infection is really, really low.
Even with an ileal colic?
Well,
Because you'd still get docked for a colon SSI on this.
if the colon was injured, I wouldn't. But if you're just taking the small bowel out and doing an anastomosis and protecting, and they had no spillage, I would close the skin.
So what do you do? We actually came up with a grading system. So grade 4 in our grading system is that you have a complete abdominal wall disruption, but you don't have any herniation. So Dr. Kwok, how would you follow a patient like this, or do you go in and repair these right away?
So I would follow. I was going to ask everybody, I don't have a very good solution of how to fix these hernias permanently. And I don't know if everyone else feels that way, but for a person that does not have a herniation, is not symptomatic, then we usually will follow up in our trauma clinic, maybe repeat a CT scan, and go from there.
Dr. Regner?
These are amazingly difficult to treat. I'd probably wait at least 3 to 6 months and then see how the patient's doing. I've repaired them from intra-abdominal approach, laparoscopic approach, and extra-abdominal approach with a flank incision. I'm unconvinced which one's the best at the moment. My personal bias is to do something that is to place it back on the iliac crest and the paraspinal muscles. The best way to do that is really open. I do have some robotic colleagues that can at least get the transversalis and internal reconnected robotically. Open, I can do all three. I'm not sure which one's the best long term.
Yeah, and then just showing this example, so repeat CAT scan at 6 months, had herniated out into there. He actually got a combination of both of them. Or actually, would you fix both at the same time? So if you had, and I don't know why this won't back up, but if you could maybe back is there because I'm pushing the wrong one. That makes sense. So would you go in and fix both of these? Would you do them robotically?
I would definitely refer it to my robotic colleague to fix both at the same time.
Yeah, I think that's not a bad idea. This was one of mine, so I actually fixed his right side first because he had actually put more out there. This was during COVID and we couldn't get him in initially, so we had to wait another 6 months to be able to bring him in to get it done, and he herniated more out into that right side. So I actually did that open and then did the left side about 6 months later laparoscopically. I kind of like the laparoscopic approach better. I'm not a robotic surgeon. Like I probably could have referred him to our robotic colleagues and maybe he'd gotten a better repair. I was worried about his loss of domain by pushing all that stuff back in there and then having failure because of tension on one of the sides. Let me go on to, I want to get to one more case here. So we've got a 71-year-old guy. We don't have much time. So this is a complicated patient with multiple comorbidities who's also had prior laparotomy for probably a ruptured appendectomy, had a subcostal incision and ended up getting a partial cholecystectomy and had a laparoscopic hernia repair one month before he showed up at our place with some referral for a right upper quadrant pain for 2 to 3 days and had this CT scan, which obviously shows that his paraesophageal hernia didn't get repaired quite well or recurred quickly. And if you look through this, he still has, sorry for my English, most of his gallbladder present in, and he's got a few hernias. He's got a right upper quadrant hernia, an umbilical hernia, and a ventral incisional hernia. Okay. And basically has a gallbladder with sludge and little bit of wall thickening, but the radiologist thought it might be secondary to his congestive heart failure and not due to acute cholecystitis because he had no pericolic cystic fluid and no inflammation around that. But he certainly was tender in the right upper quadrant. He had elevated white count and seemed to have either acute acalculous cholecystitis or acute cholecystitis. So how you gonna go after that guy?
Well, I mean, I think, oh, sorry. I think based
Oh,
off,
here, I'll just give you choices. Yeah.
I mean, I think there's a lot of different options. I mean, the question is, do you do something percutaneous to take his gallbladder out? I think that the data are not good, but the best data would say if they can undergo general anesthesia, you're best off going and taking the gallbladder out. So I think that'd be the real question. I mean, obviously he's got a lot of comorbidities, but if he could undergo general anesthesia, I think the best thing is go in and get out the remnant of the gallbladder and be done with it. More challenging than said, but I think that'd be
Yeah.
the best.
Okay. Dr. Kwok, how would you go after this guy? Multiple morbidities, hostile abdomen, and no stones that they could see on ultrasound or on the CT scan. Sludge.
I agree. Surgically, if he can handle general anesthesia, a surgical removal of the gallbladder would be the best. I would probably look at his NSQIP surgical kind of a risk factor and talk to him as well and go from there. If he's, very, very high risk, then I would do the percutaneous route.
Dr. Margulies?
Yeah, I mean, along the same lines, it's best to get it out if you can. If you feel there's such high risk, then, one of the options of either percutaneous hepatic drainage or endoscopic drainage into through the cystic duct to establish that. And you want to make sure that paraesophageal hernia is not what's causing his pain as well.
Yeah. He was very asymptomatic, no problems there. So we actually put an axiom stomach. We consult. So I had been on EGS and they were hot. We get acalculous cholecystitis consults probably routinely on our acute care surgery service. And one of our interventional gastroenterologists had been hounding me that week to find him some cases that we might have sent to interventional radiology for percutaneous drainage and said, hey, we'd like to see some of these for transpapillary or transduodenal. So we gave them the opportunity to do that in this patient. And thus far, he's about a month out. It's successful, but they put in one of the Axios stents.
Have they published any long-term outcome data on this, or is this is
Actually-
my first time to see this, so that's the only reason I'm asking.
Well, that's why I kind of put this up there. The bottom article there shows actually some decent data in regards to it compared to percutaneous drainage and transpapillary drainage in these patients. You'll never, ever want to go back in on this patient. He's not one that you're ever going to operate on that gallbladder because then you're stuck with this device in there and a duodenal fistula. Yeah.
Yeah, it just seems like if you gave me that option versus a percutaneous, I would just do percutaneous because now you put a hole in the small bowel in a foreign body. It just seems like a disaster
know.
waiting to happen. But I'm probably
Yeah, but
conservative.
if you look at this data, the percutaneous data, they'll have a large number of recurrences and lots of changing of stents. I tell you from experience, when we have to go in and operate on those or we get talked into operating on them, they just have horrible outcomes. So we're giving it a try. I know we have hepatobiliary people and President Kothari, what's your opinion on this?
So this is, you're talking about the Axio stent. This is the stent that it was originally, its original FDA indication is for the pancreatic necrosectomy. So you can dig out the peanut butter through the stomach on the pancreas. And then they have then taken that now into the Bertic world to create a iatrogenic gastrogastric fistula from the pouch to the excluded stomach, that which we fear forming as a Bertic surgeon because they're hard to take down and fix at times with increased morbidity. And now our GI colleagues are purposely doing that so that they can do ERCP and clear a common bile duct by just passing the scope now right down into the excluded stomach and clear that. And then they either try and pull that stent out, and then if it doesn't close, then we have to go fix it again. And so we have gone so far as our Bertic Society to take out a position statement kind of warning that shouldn't be first-line treatment. A laparoscopic assisted transgastric ERCP works pretty good with minimal morbidity. In my own personal institution, even though it hasn't worked 100% of the time, we try to say if our GI colleagues are going to do this, they have to have our permission first. I mean, hostile abdomen, elderly patient, where, maybe a minimally invasive approach and endoscopic works. that's the way to go. I can't argue with that. But just to do willy-nilly just because you don't want to save the patient a couple of poke holes is probably not the right thing. But then now they're doing this EOS guided drainage, and the question is percutaneous drainage versus internal drainage, you know, the next great debate. So I don't know. Time will tell, I guess.
Yeah, time will tell. We went in this thinking they were going to do a transpapillary, and then he came out with this stent in. I was like, well, okay, I guess I'm going to be dealing with him for a while. So, well, thank you. I had a couple more cases, but I think we're bumping up on our lunch hour here. And so appreciate everybody's input and the panel. So thank you all.